Welcome to our world. This is your global.
All who are joining us today. So myself and Akhil are gonna run the session. I'm gonna first talk about genomics and how we are implementing genomics in the neonatal care, and then Akhil is gonna talk about epigenomics. And then we're gonna have questions, or we can have questions, my talk, then questions, then Akhil's talks, then my questions, and then we can have an open discussion of whatever questions may come up, I think. And then we have a couple of posters that we wanted to present as well. All right, so I'm going to start by talking about genomic sequencing in the NICU. So I want to start by talking about a case. This is a case that I took care of when I was in Boston, where there was a full-term baby who was born to a 23-year-old mom, 41-week gestation, primary gravida, who baby was born with normal Apgars, and on first day of life was sent with the mom to the regular nursery. And then child was noted to be having some pallor, some hypotonias, also poor feeding, so was transferred to the NICU. And as we do, as neonatologists, we do septic workup, which was negative. And then we did a head ultrasound, some basic x-rays, echo, eyes, eye exam as well, and then child failed hearing screen. So there was something going on. Anyway, so on day 3, because of this persistent hypotonia and poor feeding, they did MRI and was noted to have some abnormal T2 prolongation and some changes in the white matter, and also some gyral folding pattern abnormalities. And then we also did MRS, which is magnetic resonance spectroscopy, and that showed a small lactate peak. So something was not perfect, but we could not pinpoint. But anyway, we got the neurology, genetics, everyone to come by and do a consult on the baby. And they did their own workup, which is usually they will send plasma, urine, CSF for all the metabolic workup, and everything came back non-diagnostic. Child also had a microarray, which was negative as well. Anyway, by day 16 or so, child was stabilized with some periodic breathing, was started on caffeine, had passed car seat test, and was sent home on caffeine and home monitor, hoping that everything will be okay. 2 days later, when the child spent with family, was noted to be seizing at home, was having apneas, and parents were really worried that something is not right. And they brought on a Sunday morning, I was on call, and the baby arrives in the NICU, and child was noted to be seizing. We did a EEG, and there was multifocal seizures that were treated with phenobarb. And then the MRI was done, which showed that the MRI was much worse than before. Child had marked reduced diffusivity in the globus pallidus thalami, corticospinal tract. The lactate peak was worse as well. Then again, more testing by the neurology metabolic team, and they still had no clue. At that time, we were doing a study where we were doing rapid exome sequencing. So this family agreed to participate in the research study. We sent samples for trio exome, which means both parents and also the baby. And the parents were agreed to the study, and then we were able to send this test. We also saved some cells. So we took a skin biopsy and saved the cells for future use. You never know, you may need them. Anyway, the baby was redirected care. Child died on day of life 27. Did an autopsy as well. Family was young, 23-year-old mom. She wanted to have more babies. She really wanted to know what's wrong with her child. Autopsy also was not very suggestive of any clear diagnosis. There was some steatosis, some left ventricular hypertrophy, but nothing that could fit into a diagnosis. So luckily, because the family agreed to do this research study, we did a rapid exome sequencing where we found that the child had 2 variants in a gene called HIBCH. We don't need to get too much into this gene, but basically this gene is critical for valine metabolic activity, and lack of this protein causes a Leigh syndrome-like picture, which is a mitochondrial disorder. Unfortunately, we had one variant which was pathogenic or likely pathogenic variant, but the second variant was a VUS. And those who know, who have seen some reports of genetics will know VUS stands for variant of unknown significance. So how do you deal with that information? So then we said, there was also the presentation of the child was not typical. Child had some C4OH activity, was not suggestive of this condition. Anyway, so we decided to, because we had the cells stored for this baby, we sent it to a lab in Europe, and they were able to measure the HIBCH activity, and that was markedly reduced in the child, thereby confirming the diagnosis. So now we had a clear diagnosis that this child has HIBCH deficiency, and that's what can explain the phenotype. But then this family used this information for prenatal genetic testing and, in fact, pre-implantation genetic diagnosis. So the embryos were looked for these variants, and if the embryos were negative for them, then they were implanted, and she has now 2 healthy boys and a girl. And this family, in fact, decided to make this testing more available to everyone. So she has been funding our lab for many years now, and they have raised about $1 million to support this cause, and they keep raising money so that we can continue this type of work. So genetic disorders in the NICU, I think, are, by some estimate, about 10 to 20% of the conditions when we admit a baby in the NICU has some type of genetic disorders. And many of these infants undergo a long diagnostic odyssey, where often taking months, even years, and still we may not have an answer. And selecting a right test can be challenging. So genetic disorders are leading cause of admission. They're associated with high risk of mortality, increase in resource utilization, and also prolonged hospital stay. So it's important to figure them out. So what is the right genetic test for NICU infants? And we can talk, well, we can have more discussion, but if you look at the evolution of testing, it started with karyotype, then came FISH, microarray, targeted mutation analysis, single gene sequencing analysis. And these each has their own indication. So for certain types of conditions, we still have to use them. For example, for newborns with trisomy 21 who have a Robertsonian translocation, we should use karyotype because that's the best test for that. For trisomy 18, 21, 13, FISH is a great test, or fluorescence in situ hybridization. Infants with multiple anomalies, microarray can be used. We can use for achondroplasia, we can even test for a certain mutation. Marfan syndrome, you can have single gene sequence analysis. And then there are other ones like deletion duplication analysis, methylation analysis. Gene panel, they are becoming more and more popular in last many years. And when their child is born with hypotonia, for example, there is a hypotonia panel. When a baby has seizures, there's a seizure panel. And these panels are basically a collection of genes that are all combined together. They often have a genome platform where they look for variations in these genes. But more and more we are moving towards exome and genome sequencing, and that also rapid. Most of the cases nowadays we are using rapid genome sequencing. We are not using exome sequencing because I think this is a relatively inferior test compared to rapid genome sequencing. Those of you who don't know the exact difference between exome and genome, exome is basically sequencing the coding portion of the genome, which is 1 to 2%, and then genome is trying to sequence every part of every base pair of the genome. So that's the difference. And there are a couple of types of genome sequencing. One is called short read, one is called long read. We don't have to get into that. Most of the sequencing is done on short read, which means there are smaller fragments that we sequence. And that's the established technology right now, but more and more we are also looking into long read sequencing, which has a better quality of data. So today you heard about the floppy baby, right? We talked about that in the Prader-Willi case. And it used to happen that, in fact, one of the reasons why I got interested in this field was I was a neonatologist as a fellow, and I took care of a baby who had some type of floppy disorder where we could not figure out what's wrong. It took us 6 months those days. This is 2001. And finally, we found that the child had a condition called myotubular myopathy. Those who you don't need to remember this term, but this is one of the rare 1 in 50,000 cases of a condition which is due to a mutation in a gene called MTM1. So finding that cause of that patient took us 6 months, and that was my sort of something told me that we need to work on this. This is taking way too much of time for us to diagnose a patient with this type of condition. So think of all this testing that these babies undergo, and I'm not going to read all of them. We're going to spend the next half hour reading all of them, but just think of the extent of testing that goes on with this kid, and replacing it with a single test, which is rapid. We can get an answer in 3 to 5 days. So that's a difference. 20 years back, it used to take 6 months. Or 3 to 6 months to really, and sometimes we still did not have a diagnosis. Now we can have a diagnosis in 3 to 5 days. So we do believe that this is something that we need to think about every time we see a baby with hypotonia or other conditions that I will talk about. So this is a study we did when I was at Boston Children's, where we did rapid exome sequencing during 2017-18, and we enrolled 52 babies from Boston Children's and other Harvard-affiliated hospitals, and we wanted to look at the diagnostic yield, how much time it took, and what was the impact on care. And then we came up with our own criteria, because at that time there was as neonatologists, we rely too much on genetics to decide who to send the testing for, but we came up with our own criteria that if a child is born with unexplained hypotonia, unexplained seizures, or he has multiple anomalies, or if there is some other metabolic disorder or sex differentiation, or some unexplained severe lung disease or immunodeficiency. These are some of the 7 or 8 criteria that we came up with. And what we found was that we approached 57 families. We were able to enroll 52 of them in a short period. So it's about a year plus a little bit longer than a year. And we were able to sequence 50 of them. And out of those 50, we were able to diagnose 29 of them, which is 58%, which is pretty high diagnostic rate. And this is partly because we cater to a lot of babies who come with unusual diagnoses or unusual findings, and they come to our hospital for further care, like the case I talked about. So that case was also part of this study. So anyway, for the other 21 cases, we also obtained the data for reanalysis, where I will talk about it a little bit later. But how did they affect the care of the patients? So first, there was a patient where we found a mutation in a gene called SCN2A. This is a gene which is involved in sodium channel. It's a sodium channel protein. It is involved in channel sodium flux. And mutations in this gene are more responsive to phenytoin. So this child has not been tried on phenytoin. So we used that and had a better response to that drug. There was another kid who had MTM1 mutation, and at that time, there was a clinical trial going on with MTM1 mutations where you can try a gene therapy on these patients. We also referred to additional specialists. Many families benefited from reproductive decision making. So the family I described, the first case, they used this information for reproductive planning, and they now have 3 kids. And there are several other families who had the same outcome where they used this information. Then there was this rapid, we could do like tracheostomy or gastrostomy or this type of intervention for these patients with hypotonia, for example, that we don't have to wait for months to get to diagnosis first and then go for it. Once we have a diagnosis, we can plan better, faster, and that can save time. And in one case, I remember we were able to even provide early comfort care. So this is a unique case where we had a baby who had some subtle apnea and some subtle dysmorphism. Nothing fits into a phenotype. This family agreed to participate, and we found that this child, in fact, had a mutation in a gene that causes Lesch-Nyhan syndrome. You don't have to remember the condition, but it basically involves severe neurodevelopmental issues, and they also have tendency to self-mutilate. They have the worst quality of life. And because of our early diagnosis, this family did not have to go through all this pain of taking care of this kid for several years down the line. They decided to redirect care, and the child was allowed to pass for comfort only. And that really is an example where genetics can it can help in so many ways. That's the message. So more and more we are realizing that rapid exome or genome sequencing should be the first-line genetic test in infants, in NICU infants. And there's plenty of evidence that is coming out from different parts of the world, including US, Europe, and Australia, and many countries and Middle East as well, where we are showing that we can have high diagnostic yield of 20 to 60%. We can decrease the time to diagnosis. We can have significant impact on clinical care. It has been perceived, multiple studies have shown, including ours, that clinicians and patients, or parents of the patients, they really think that this is a great test and is cost effective. So it has all the benefits that we can imagine. These are some of the studies that I put a summary on, and if you look at these studies, they started from 2013, and since then we have several studies, including one of our own study, which has shown the diagnostic yield to be about 37%. And there is some exome, older studies are more exome-based, and newer studies are more genome-based. So more and more the US American College of Medical Genetics and Genomics is recommending that we should consider exomes or genome sequencing for infants which are less than 1 year of age, who have multiple anomalies, or those who have developmental delay or intellectual disability. And then there is a Society of Genetic Counselors who also suggest that we should, for individuals with unexplained epilepsy, we should use this exome or genome as the first-line test. And then we did this study ourselves, published in JAMA Neurology and then in Neurology, where we showed that for NICU patients with unexplained hypotonia, we can have a diagnostic yield of about 60%. And this was a study done across 3 continents. We had from Boston Children's, from Sick Kids, Toronto, we had from Cambridge, from Australia, from Royal Children's Hospital, and one more place. So 5 centers, 5 big children's hospitals, they came together and sort of we showed that this has a great utility in the diagnosis of these infants. So who's the right infant? So that's a question, like how do you say that this is the right infant for rapid exome or genome sequencing? A lot of people in the neonatology space, they rely on geneticists, but I think as we are the first line caretakers, we need to come up with some criteria to decide who's the right patient. So this is some of the inclusion criteria that we have come up with, and this is pretty elaborate. If you look at unexplained hypotonia, seizures, metabolic, mitochondrial, anomalies, renal, pretty much every organ system that affects babies in an unusual way you can think of will be a good candidate. Chronic diarrhea, recurrent infections, positive newborn screen, or skin conditions like epidermolysis bullosa. And then there is another big slide which tells you in more depth about what are the different conditions. Same thing, single anomaly, multiple anomaly, pulmonary disease. It's pretty much what I've told, but in a little bit more description. So I'm happy to share if you're interested in the slides. And then this study that came last year from Seattle Children's, where they said that why are we even talking about inclusion criteria? How about exclusion criteria? So let's sequence every baby who is in the NICU and not include those who are premature, who have infection, or who have physical trauma. Other than that, every baby who comes to the NICU should undergo sequencing and see what the findings are. And what this showed was it was remarkable that they got a 49% diagnostic rate in the intervention group. So they consented the family for either the intervention arm or some who said no. So they followed the typical course, which is either gene panel or microarray first and then all the other testing. And what they found was, or they were dying or not alive, or some of these kids who were missed. So they were in the separate second group, and they found that the diagnostic rate was 49% for the intervention group and 10% for the control group. So that shows that there was a lot of, there is some basis for using this as an option. And what this showed was that up to 9 times more likely to receive a genetic diagnosis, and 49% of infants had their condition fully explained or partially explained, and 49% had fully or likely or partially explained, and 29% were fully explained by rapid genome. So those were the findings, and these are some of the anomalies they sequenced for. You can see hematologic anomaly. There was 2 infants, abnormal lab test, and then the diagnostic rate was 100%, 70%. It's all over the place, 53%. The message is that all of these conditions, the high diagnostic rate was fairly high, which is important. So how does rapid exome or genome sequencing helps in the NICU? So first is that it can change medical management, it can reduce healthcare cost, and many infants have a genetic disorder. It can reduce their length of stay. 33% of critical infants who avoid invasive procedures. Sometimes families decide to redirect care instead of going for the invasive procedures. They sometimes, like 70% have medical changes, meaningful medical changes. And then this study showed that 42% of infants who could not receive a diagnosis by conventional care could get it by rapid genome. So I think this is an important area that we are trying to spread the word that we need to think of rapid genome sequencing in the NICU especially. These are some of the cases where you would not have suspected that there will be a genetic basis for the condition. For example, this was an infant who was admitted at a place with colonic atresia, which is a very surgical condition, and had multiple post-op complications, underwent rapid genome, and was found to have a mutation in a gene called TT7A. So this is a gene which is well known, and it also causes immune dysfunction. So was noted to have hypogammaglobulinemia and decreased T cell function, so was treated with IgG replacement and Synagis. So that was the benefit. The other one where you will probably never do rapid genome either, or genome sequencing. This was an infant with intraventricular hemorrhage requiring multiple transfusions, and there was suspicion for a bleeding disorder. And then they did rapid genome, found that the child had a variant in F9 gene, which is a hemophilia, and was treated with recombinant factor 9. And this is another example where they found a variant in a gene called JAG1 in a child who was going to undergo Kasai procedure for biliary atresia, and that was based on the outcomes associated with this JAG1 mutation. This was decided not to do Kasai, and in fact, the outcome could have been much worse if Kasai was done on this infant. So there are a lot of these anecdotal examples of cases where rapid genome sequencing can really make a change in the care of a patient. I'm not saying that every baby will have a benefit like this, but there are examples where it can really change the care of the child. This was a study done in UC San Diego, where this is called Project Baby Bear, and they showed that the rapid sequencing had a high diagnostic rate of 40%, and the cost saving was $12,000 to $15,000. And then it also shortened the stay by up to 20 days. So there are multiple benefits and multiple levels, and that's why the need for using this technology more often. And these are some of the examples where having a diagnosis can give you a specific treatment. So for example, if you have a mutation in a gene called FOLR1, you can treat with just folinic acid. That's the treatment. Similarly, if you have a mutation in ALDH7A1, you can treat with pyridoxine and folinic acid. And similarly, PNPO, and I've seen cases of PNPO myself where we have used this drug or supplemental pyridoxal 5-phosphate. And there are many more. I don't want to go through every one of them, but this just shows that there are so many genetic conditions where you can have a direct benefit to the patient by having a diagnosis. And then there are many of them where you can do a bone marrow transplant that can cure the patient, where if you don't have a diagnosis, that patient is not a candidate. And these are some of the examples of that: FHL, X-linked lymphoproliferative disease, and many other, CGD. And all this can, once you have a genetic diagnosis, you can do bone marrow transplant, and it can be potentially curative. So one area which matches with the goal of this conference is how can we implement genomics in resource-poor NICUs or resource-constrained NICUs. That in US also we have this problem, but many countries is like, how can we implement genomics in there? So we had this study which we called VIGOR, Virtual Genome Center for Infant Health. We built this study where the goal was to implement genomics in resource-poor NICUs. So the goals were like free rapid genome sequencing, free education and support to NICU providers in report interpretation and disclosure, consultation with genetics expert. We also did reanalysis of unsolved sequencing data, and then access to cutting-edge therapeutic innovation. So these are the goals of this study. This is funded by NIH. So we are right now, this is the team, myself, Tim Yu, and Mike Parker, and then there are a lot of genetic counselors, neonatologists, geneticists as part of the team. And these are some of the sites from where we are enrolling patients from Boston Medical Center, UMass, Bay State, Cooper, and then some of the Texas sites, and Miami, where I am right now at. So what are our goals? One is that we want to build this network, and we want to use telemedicine as a way to approach all these sites and enroll 250 newborns from these 10 or so sites. We want to facilitate sequencing. We want to create comprehensive report and also reanalyze genomic data. So a lot of times when you send a genome, you will get a report like, we don't know, we have 2 VUS or we have nothing, it's negative. What do you do with those cases? That's what we're trying to do, is to get the data ourselves, look at the data ourselves. We have a whole team working on it, and make sure that we get the most updated data and analysis and technology to make sure that we are not missing anything, but we are also sometimes finding new genes in the process, and I'll show you some examples of that. And then we are looking at the implementation outcomes, whether how appropriate, how feasible, how much penetration, equity, and satisfaction from parents, and also from physicians, and mental health and clinical outcomes. So this is our inclusion criteria. Any infant who is admitted to the NICU with these diagnoses, these are some of the examples that we are trying to enroll patients with these conditions. It's not limited to them. We need at least one parent to consent, and then parent needs to follow the child for 12 months at least. And these are some of the exclusion criteria. I don't need to go through all of them, but if you have a known genetic diagnosis, or you have an obvious trisomy 21, or if you have a low chance of finding anything, we are excluding those. Our goal is to preserve our resources to use for the best cases. And then what we do is to collect the samples. We get the rapid genome sequencing in 5 to 7 days. We create our own report. We disclose the results to families. And then if it's a positive result, how it affects the diagnosis, management, research. And if it's a negative, then we do reanalysis. So this is one example of what we are doing. So this is a report. Typically, if you are working in the US especially, you will see a report like this, where we had an infant who had a bad lung disease, 34-weeker, and we enrolled this patient, and we sent rapid genome, and we found something which is called SRCAP. There was a variant, de novo variant, which means both parents don't have the variant, and it's likely pathogenic. But SRCAP has never been linked with lung disease, so what does it mean? And then we got all this information from the lab. If you look at, as a clinician, you will be like, okay, I don't understand one word, I don't want to read this, it's too complex, right? So our goal is to simplify this. So that's what we create by creating our own comprehensive interpretive report we call CIR. And this is how we start. We say this finding is likely of clinical relevance. SRCAP is associated with SRCAP-related neurodevelopmental disorder, and consider further clinical workup. And we recommend referral to a clinical genetics or genetic counselor. But then we talk more about the variant and the disease information. So we say this variant has been previously reported, is associated with SRCAP-related neurodevelopmental disorder. This variant causes a small duplication in the gene, which leads to frame shift and a premature truncation. It's outside of exon 33 and 34. So if anyone has heard of floating harbor syndrome, that's where the hot spot is for this gene, where it's mutated in between the hot spot of exon 33 and 34. But this mutation is not located there, so that's not related to floating harbor. And then there is no known association between lung disease and SRCAP. And then we talk about what are the different things we need to look for. Developmental delays, including speech delay, behavioral challenges, hypotonia, joint laxity. These are the things to watch for. These are other things they may have, microcephaly, mental health issues in the future, autism, seizures, hearing loss, myopia, strabismus, genitourinary malformation. And then again, you have to remember, this is a newborn, or a few months old, or maybe less than a month old, who was enrolled. At that time, a lot of these manifestations will not show up. So it's important information that may be very, very relevant to the child when he grows up. And then in terms of workup, definitely go to a geneticist, get a follow-up, but also look at methylation analysis. And I know Akhil will talk about some of that genomic stuff. But there are many conditions that are related to methylation defect. And this gene has a methylation signature that may be useful to further diagnose it. And then you do hearing exam, you do eye exam, neurology, and then we also give them research opportunity where we can link them with Simon Search Light Foundation, which does work with this type of genes. And then we also provide them that we are going to reanalyze the data, that in future we may find something that may explain the pulmonary disease. We will keep analyzing it so that we may not miss something that can explain the pulmonary disease. So why do we reanalyze data? So only 25 to 40% of families get a genetic diagnosis. Remaining of them don't, because there are a lot of knowledge gaps that still exist. As we know, only 55 out of the 20,000 genes, there are only 5,000 that have a genetic diagnosis, that have a clinical link. Remaining, we still don't understand. Many conditions are also, there's expansion of the phenotype, where you have a gene that you know is mutated in a certain defect, but there may be more defects that you may not know about. So more needs to be known. And that's the other problem. And then there's the issue of variant of unknown significance and candidate gene. This is just to show some of the work we have done in this space, where we have looked into clinical exome where they did not have a diagnosis, and we got the data ourselves and looked at by my team. We looked at it together, and we found that in fact 6 of them had a variant in known genes, which were missed or which were new genes that were not identified by the lab and we were able to find. So those were the 6 genes and 6 patients where we found some new finding that were not explained by the report. So that's something to remember, that if you don't get a positive finding in a child where you strongly suspect there is a genetic condition, don't give up, because there may be more, something more that may be hiding in plain sight. So that's what we do. But if you look at this, you see there are 15 patients who had some candidate gene. Candidate gene means the gene is of some suspicion, but right now we cannot link the gene with the disease. And there were 15 found by the lab itself, and there were 16 found by, or 18 found by us. So there were 33 genes, genetic variants, which were candidate genes, but they were not linked to a phenotype. So what did we find? In 4 years' time, since we published that, we showed that 16 of those 33, we found that candidate genes were indeed disease-causing, which means that these were novel genes that we were able to find more patients all around the world, or we did some more work and found that this is indeed the disease-causing. And that is a big number. 50% we could find the genetic diagnosis for them. Now this was aim 3 that I'm not going to go through it, but we really wanted to look at also what is the benefit of this technology, or how are the families dealing with it, and what are the outcomes. All this is being studied as well. So these are some of the results from this study. This is preliminary data. It's not published yet. We have already enrolled, this slide is a little old. We have already enrolled 210 infants, and we have found a diagnosis for about a third of them, or a little less than a third of them that we have a diagnosis for. And these are some of the publications that has come out from our work in this space, in this vigor study. So we published in BMJ Open, we published in Genetics and Medicine, a couple of papers, which is one of the journals for any genetic literature. And then, I talked about reanalysis and why it's so important to not give up on these families who don't get an answer despite sequencing. And that's where it's very important to understand the concept of gene discovery. So we built this Manton Center for Orphan Disease Research in Boston, where one of the first centers in the world dedicated to rare disease research. So our goal is to really help families who don't get a diagnosis or who are struggling with a child with an undiagnosed condition, to really help them. There were 5 programs, and I'm going to focus on Gene Discovery Core. So this Manton Center, we have been able to publish more than 750 peer-reviewed papers. There's accessible biorepository for orphan disease. There are many novel gene discoveries and phenotype expansions, results returned to the families. A lot of collaboration with academia, industry, a lot of NIH funding that came out of it. And then we are also very engaged with the rare disease community, because these families essentially feel themselves lost, and we are trying to help them connect with other families, but also provide them with support as needed. So this is one example. This is the Gene Discovery Core I'm talking about. We have this protocol where we can enroll any patient who has an orphan disease or rare disease, which we can get their data, we can get their samples, we can create cell lines, we can create animal models, and then we can really try to figure out. This was one case, one of the very early cases that we found. This is a mom who had twins who were born in another state, both on day one started to have seizures, and one of them died at that place, so they decided to come to Boston Children's. And we did whole genome sequencing on this family. We could not find an answer for several years because the gene was not known. But when our work recognized that the child, in fact, had a mutation in SCN2A, which is the first explanation of SCN2A gene with Ohtahara syndrome. In fact, we were able to get the sample from the deceased twin, their brain sample, and we could confirm that that twin also had the same mutation. So that was further confirmed that this is indeed the disease-causing mutation in the family. Because this was de novo, this family went on to have 5 more kids who are all doing healthy, and even though it did not help the patient directly, at least that information was used by them for reproductive decisions. So this is some of the work we are doing within this gene discovery core. Gene discovery, we also do a lot of gene modifiers. So for example, cystic fibrosis, we have found some of the interesting modifiers for cystic fibrosis on the sodium channel, chloride channel, some of the channelopathies, which I'm not going to talk about today. And then we're building disease cohorts. So many times these diseases are so rare, you just don't have enough patients. So it's important to build cohorts of these type of disorders for the genetic analysis. And lastly, our ultimate goal is to support development of personalized therapies, which I will talk about a little bit later. So these are some of the specialties we got enrollees from. This is a very old slide, but I want to show that every division, every type of subspecialties need genetics. That's the message. Neonatology definitely needs, but not only neonatology, surgery also needs. Cardiology or neurology, pulmonology, urology. Think of any field and you need genetics as part of your workup, because there are many conditions which have an underlying genetic basis that needs to be figured out. So we have already enrolled 2,500 plus families. We are doing a lot of them are N of 1. We are doing all this different sequencing. We are analyzing. We have our own pipeline to analyze this data, which we call it the VEXP, developed by a bioinformatician who has been working with me. And then there are other ones like Seeker from Broad Institute. If people know Broad is at Harvard and MIT. It's a genomics institute, big one. And then there are other platforms too. This is some of the work that we have published in last 10 years. A lot of new gene discovery that has come out, and this year we had this gene called WSB2 published, but every year we have 2 or 3 genes we are finding new genes that come out of this type of work. So that it not only helps the families, but it also helps advancing science. And lastly, I want to talk about personalized therapeutics, because that's the future that we are talking about, especially for genetic disorders. So this was a case, a girl who was enrolled by us in the Manton Center, who was raised in Denver area. She had some type of condition where she was seizing. She had neurodevelopmental delay, regression, and she was really going downhill. She was getting blind. And this family was desperate, so they put a posting on the Facebook to find answers, what's going on with my daughter. They did exome sequencing and they found 1 variant out of 2, because you need 2, because it's a recessive disorder, or you're homozygous, so you need 2 variants. They could find only 1 variant, which means she may have a second variant hiding somewhere, or it may be completely different disease. Anyway, this posting by the mom was seen by one of my colleagues, Tim Yu. His wife saw it on Facebook because she used to follow that, and then she reached out to him and he reached out to us. Anyway, long story short, we were able to enroll them. We could find the second mutation in the same gene using whole genome sequencing, and there was something called insertion of a transposon in one of in the intronic region, which was called creating a new exon. And the fact that that particular variant was creating a new exon, it was amenable to antisense oligonucleotide. So this is one of the ways that you can really create a personalized therapy where the drug was created by Tim and his team targeting her mutation. And this is the process. She was referred, her cell lines were established. She had this splice defect was identified. I was telling you this, an extra exon which was being created because of this transposon insertion. They created antisense oligonucleotide, confirmed the functionality, and then FDA approval, followed by some rat models, and then treating the patient. All that happened within a year, and she had a significant benefit from this. She lived for another few years. Unfortunately, the disease was so advanced that it was irreversible, so she died, but this has really changed the field. Since then, many more studies are coming out where people are showing that, in fact, you can create these type of drugs for specific mutations which are amenable to ASO, or antisense oligonucleotide. There's also more interest, as you know, many new drugs have been approved recently on sickle cell is one example, Casgevy, and there's one more from Bluebird Bio. So that's the new future for a lot of these genetic conditions: gene therapy, CRISPR-based therapies, antisense oligo-based therapies, repurposing of drugs, new molecules. All this is coming, and we just have to find the diagnosis to really find treatment. So in fact, we just wrote a grant to NIH to really implement this approach in the NICU itself, and we are going to get funded. So looking forward to that work, where we are going to try to not only identify these patients, find the right mutations, and then try to develop drugs specific for that mutation using the antisense oligonucleotide. So that's the future. I'm just excited about being in this space where we can really make a difference. And then I built this neonatal genomics program at Boston Children's, where we created, I was the director, I was the first director, we had faculty, fellows, genetic counselor, and then we have research assistant. We did all these things. We did rapid sequencing, molecular autopsy, data reanalysis, integrated with other technologies, including RNA-seq, methylome, and others, and then function analysis, how to integrate with community NICUs, build a biorepository, and then the final goal of developing precision therapy. So that's our goal, but this is how we were able to achieve all this, and I have moved since then to Miami, and I'm building the same thing in Miami as well. But it's really exciting to be able to do this type of work. And so my summary slide is that rapid genome sequencing in the NICU provides faster answers to families and can impact treatment and management. Implementing sequencing in under-resourced NICU is critical, and we use telehealth approach, and that's one way to do it. Educating and working closely with providers to implement genomics in the NICU is critical. And then I cannot emphasize how much research we have been able to accomplish because of this technology, and also because of the potential for these approaches that we can do. So this is my team that works with me, and we have a lot of funding from NIH, and also this is the family because of Bella Foundation that raises money for our research. And this is the Vigor team, and then this is my laboratory, and I will be happy to take any questions. Yes. Yeah. Yeah, that's a great question. There is a database where you can share these variants in something called Matchmaker Exchange. So you can put your variant in that data, and then anyone in the world can match with that. If they find if let's say you have a variant in a new gene and you put it in, there you will see, as soon as you put it in, you will see you are matching with 10 different places in the world. And then they will reach out to you, or you can reach out to them. And that's how you can build a cohort of patients with the same gene. Yeah, appearance is critical because you want to find variants. First of all, it needs to be in trans, or it should be de novo, where you are, it has to be determined that is it a new variant in the child which both parents don't have, or they are recessive for it.
Thank you very much for a fascinating lecture. I have just a simple question. Could you comment on the possibility, future, that we screen every newborn?
Yeah, so I did take out those slides because we have been working on screening newborns for all types of conditions which are potentially treatable or which have an impact on care. So I don't know if you've heard of BabySeq. This was a study done in Boston and Brigham and Women's, where we did sequence every healthy and sick baby, and we sequenced about 150 of them. And we found about 10% of them had some variant that had some implications for their management in the future. But since then, many more studies have started in Europe and US and Middle East, where they are using this to, like, especially in areas of the world where there's a lot of consanguinity, they are really implementing in a big way to really test these prenatally or postnatally. Like, there are so many programs going on right now where they are using this as in research, but that's coming. In fact, last week, state of Florida wants to now implement it in babies who are born in Florida, all babies to undergo a set of genes. Like, we are coming up with a list. I'm leading that effort, and we are coming up with a list of about 500 to 600 genes that every baby who is born will be screened for any variant, so that we can develop these personalized therapies in the future. Yeah, but that's a great question. That's something on the horizon, which a lot of excitement around it.
Thank you.